some blanks. So what I'm going to do today is I'm going to talk about naturopathic medicine, and I'm going to talk about what we do at the Sherbourne Health Center clinic, and then we'll leave lots of time at the end for discussion, and we can discuss anything you'd like that's relevant to naturopathic medicine or anything else beyond that as well if you want. So for those of you who don't know where the Sherbourne Health Center is, I assume most of you do, but it's just right across the street from the lovely Allen Gardens right here. And the naturopathic clinic is actually right in the wing here, right in this here. And we've been here, been there since, I think it was 2002 that we moved into that building. Before that, we were in the PWA building at the corner of Church and Carlton. And we moved into these nice new buildings in about 10 years ago. So I was around for the start of this part of our adventure. So this is a joint part. The Naturopathic Clinic is a joint partnership of the Sherbourne Health Center, the Canadian College of Naturopathic Medicine, and the Toronto People Living with AIDS Foundation. And we used to receive support from the AIDS Committee of Toronto as well, up until about 1 or 2 years ago. So this is actually a teaching clinic and of the Canadian College of Naturopathic Medicine. I'm not sure if any of you know this area. Anybody make it north of Bloor into the northern part of Canada? This is right at the corner of Sherbourne and Leslie, just north of the 401. And this is our campus right here. We have a fairly large campus. It's a 4-year program. And we have about 400 to 500 students in the program. So if you come to the Sherbourne Health Center, you're exposed to students in their final year of training. So just at the end of the 3rd year, students enter their 4th year and they do clinical rotations. And then some of the students will do a rotation at the Sherbourne Health Center clinic for 4 months. And we have other clinics scattered throughout Toronto as well. And so let me give you an idea of what naturopathic medicine is. We're at the Sherbourne Health Center on Tuesdays and on Wednesdays, so we have 2 shifts there, and it's a free clinic. There's no charges, and we have some funding from the partners. All contribute to the operating costs. We have some donations from a number of supplement companies. They provide us with herbs and nutrients as well. We do have some money to buy products as well. And then we also receive some funding from the MacAIDS Fund. We've received MacAIDS funding for the past, I think it's 3 or 4 years. And that helps us with our operating costs and also with the purchase of product that we distribute for free. So naturopathic medicine, some of you have been to a naturopath, I'm sure, but maybe you don't know exactly what we do. We probably don't talk about what specifically naturopathic medicine is a lot. But we consider it a distinct system of primary care that seeks to address the root cause of illness or disease and promotes health and healing using natural therapies. So for the most part, naturopaths use so-called natural therapies, but in some jurisdictions they also use drugs. So in Ontario, we're somewhat limited in scope and what we can do. But more recently in Alberta, the naturopaths were given the right to dispense medications. But for the most part, they would stick to natural therapies. So for HIV care, naturopathic medicine, we consider it a complementary approach that utilizes a number of different therapies from the perspective of naturopathic principles. And I'm going to talk about what those principles are, but primarily what we're doing is complementary to antiretroviral drugs. It's not an alternative. There's no alternative, as far as I know, to the use of antiretroviral drugs for the management of HIV. So what we really do is try to complement that. Another way to look at it is there's a physician in the States, and he considers his complementary approach. He uses a lot of things that we use. He considers the antiretroviral is complementary to his natural therapies, so you can look at it either way around. But essentially, we do need antiretroviral drugs in the management of HIV. So let's look at some of these principles that govern naturopathic medicine. Essentially, they're principles that were, I consider them just principles of good medicine. And they're very similar to the teachings of Hippocrates, who's considered the father of modern medicine. He developed the oath of medical ethics. Treat the body as a whole was one of his tenets. Respect the natural healing process of rest, good diet, fresh air, and cleanliness. And respect the individuality of patients. So naturopathic principles are very much rooted in those type of principles as well. And so let me just go through some of these principles for you. The first, of course, is first do no harm, and that's not a principle that's unique to us. It's a principle that's unique that all providers of medicine will adhere to, and that means a number of different things. So of course, we don't want to provide medicines that are harmful, and we need to balance the risk and the benefit of all medicines. So one of the guiding principles of naturopathic medicine is that we want to use the safest, least invasive medications first, and then, if necessary, proceed to potentially more risky, but more effective medicines in some cases. So. On the other hand, first do no harm also means that you need to use the medicines that's appropriate for the job. So it could be that the first intervention is an antiretroviral drug. It's not that we're opposed to drugs. We just would see a particular order of importance. The second principle is to support the body's natural healing process, and we know that the body is always trying to achieve a state of balance. In traditional Chinese medicine, we're looking at syndromes of imbalance, and you're trying to bring the body back into balance. The same as in Western medicine, the body is trying to achieve something called homeostasis, and we're always trying to work with the body to do what it inherently is trying to do in order to regain health. So, for instance, one example of that would be some people have acid reflux, and it's quite painful. We don't necessarily advocate that the first place to start in that situation would be to take a drug that's going to suppress your stomach acid, because the stomach acid is there for a reason. We'd like to try things first, such as changing diet and other things. Whereas if we were to just jump in and give an acid blocker, there's some potential complications with that that may not be in the body's best interest. So the other thing that we're always trying to do is to identify and treat the cause of illness, and that kind of leads into the next principle, which is to treat the whole person through individualized treatment. Because if you're looking at really addressing the causes of illness, we know that illness is multifactorial. So we need to look at lifestyle. We need to look at socioeconomic factors. We look at mental health factors, as well as the physical symptoms that someone's presenting with. So we're really trying to look at the whole individual and apply treatment based on that. I think it's something that even modern medicine is trying to look at more and more now with integrated healthcare. But that's been sort of a mainstay of naturopathic medicine since the turn of the century. And the next principle would be doctor as teacher, and emphasizing prevention. So we know that a big part of what we do at Sherbourne, and I like to emphasize, is education. So we want to try to educate people on good lifestyle, educate people on some of the obstacles to getting better, to recovering. And we also, obviously it's much better to prevent illness than to try to treat it once it's developed. So we're not just at Sherbourne, we're not just focused on HIV care, we're also looking at just general wellness and primary health care in general. The other thing we do a lot at Sherbourne is education. So some of our clients will come in and they won't know a lot about the antiretroviral drugs or some of the benefits of antiretroviral drugs. So one thing, ironically, that we do is we give people a lot of information about why they really should be taking the antiretrovirals consistently, why they shouldn't wait too long to go on to the drugs, so it's a big part of what we do. So what therapies do we use? Some of you will know some of the things that we use because you've been to our clinic. But in theory, naturopathic medicine is more defined by the principles that I just mentioned than by any individual therapy. And as I mentioned, some NDs will prescribe drugs, antibiotics, hormones, and that sort of thing, depending on where they practice. But really, it's how you apply those drugs in the context of what I think are the principles of good medicine. But in general, our approach to people living with HIV or AIDS, we use botanical medicines, we use clinical nutrition, we use a lot of lifestyle counseling. Acupuncture is a big part of what we do. Homeopathy is used somewhat at the clinic, and then a lot of education. This is a pie chart. We did a chart review just recently, and we wanted to and I can talk about this later. We wanted to look to see if there were any safety issues with the use of these different supplements and botanicals and loss of virological control. So we're looking for evidence of harm. Maybe looking to see if any of the supplements that we're using were potentially interfering with the medications. And we weren't able to find it. But one of the things we were able to do is give a better understanding of some of the therapies that we use and on a visit basis. So you can see this is the therapies that are used per visit. So 44% of patients coming in to the clinic will get acupuncture. So it's quite a big part of what we do. We give 14% will get B12 injections. I think we're starting to see a decrease in the amount of B12 that we inject because I think it's possible to get the same benefit just doing it orally. Lifestyle counseling, 11% of patient visits involve some part of lifestyle counseling. Dietary recommendations and therapies, body work, homeopathy is about 5%, botanical medicine 7%. But you can see that the primary thing that we do is acupuncture on an ongoing basis, and there's a number of reasons for that. One of it is that it's cost effective for us because we do have the space to provide it. But we're also when we do acupuncture, it's typically something that you do on a more frequent basis, so you're more likely to have acupuncture if you're coming to the clinic more often. So one of the things that we do from the clinical nutrition perspective is, and I would include supplement use in this case. And you can see this is the breakdown of the actual supplements that we use at the clinic. You can see this is Retava. I'll talk about this in a minute. This is just a micronutrient formula that we created. Fish oil, about 80% of our patients are on fish oil. Probiotics, it's also very high. And then you can see a lot of these things are antioxidants and other nutrients. One thing that we do know is that people living with HIV tend, particularly during the early stages of the infection before treatment, there's a lot of inflammation going on in the body and a lot of oxidative stress. So and associated with that, there tend to be micronutrient deficiencies, so vitamin deficiencies early on. And what we try to do is we try to replace some of those micronutrients in products that we call Retava 412. And so early on, we had some money, so we decided that instead of buying products individually, we would actually manufacture our own product. That saves us a lot of money. So, for instance, this product, when I first did the calculations back in I think it was 2005, the bottle would have wholesaled for about $50. We were able to manufacture it for about $10. So we're able to provide a lot of nutrients that we wouldn't have otherwise been able to provide. So over the years, it's changed a little bit in its formula. But you can see if right up what this contains is a lot of it, like N-acetylcysteine, ascorbic acids, vitamin C, alpha-lipoic acid. These are all antioxidants, nutrients, and this is partly based on some research that was done by John Kaiser in the States early on. A number of years ago, he found that this combination of nutrients and some other nutrients as well were able to increase CD4 counts a little bit.
Did you get this right about 412 at your clinic?
At our clinic, yes.
At your clinic.
Yeah. So you have to be a patient of the clinic,
yeah.
but we do provide.
If you're not a patient of the clinic, you won't be able to buy it.
No, it's not available. There is another product that you can purchase. It's something similar to it. It's called K-Pax. You have to mail order it from the States, and it's actually probably a better product than this because it's more comprehensive. But it tends to be quite expensive. And there's actually a trial that we're doing, the Maintain study, and they're using K-Pax to see if we can reduce the time from baseline to treatment. So looking at patients who aren't treated with antiretrovirals and see if we can slow the loss of CD4 cells to delay the need for antiretrovirals. But this is something, and you're welcome to come. You don't have to, if you come to our clinic, you don't have to come on a weekly basis, but we're happy to accept anyone that wants to become a patient there, and we will provide this for you as long as we can. So we don't have to provide all these supplements is quite costly, and we don't have guaranteed funding for indefinitely. But as long as we do, we'll provide this and other things. We do receive products from donations from some of the supplement manufacturers as well. So you'll see some other nutrients in here, such as zinc. It's very important for immune function. Copper is in there because if you take too much zinc, you can end up with a copper deficiency. Manganese is in there because it's part of antioxidant system. Chromium, there can be chromium deficiencies in some people living with HIV, and it's important for blood sugar regulation. And then vitamin D, we're starting to see that vitamin D is important in HIV. It's not necessarily that people living with HIV are more vitamin D deficient than the general population. It's just that it may be more important in an HIV population. And there's been some research that's shown that those with the lowest levels of vitamin D compared to the highest levels actually progressed quicker to certain illness, HIV-associated illnesses. And of course, one of the drugs, efavirenz, is also known as Estiva, is probably interferes with the metabolism of vitamin D. So in a number of studies now, it's been shown that those on efavirenz tend to have lower vitamin D levels than those on other drugs. And then selenium, of course, is also involved in immune. So another big thing that we do is lifestyle counseling, because it's a big component of preventative medicine, and it's partly about educating people on healthy diet. It's much better to have to eat well than it is to take your nutrients in a pill form. So even though we provide nutrients, there's no replacement. You can't get good diet in a pill. So we're big advocates of eating well, exercise, healthy sleep hygiene, and that sort of thing, stress reduction. And then we do a lot of acupuncture at the clinic. most of the acupuncture that we do is focused on pain management, but we use acupuncture for a lot of other things as well. I'm going to skip over homeopathy. It's not one of my strong points, but a number of the students in our clinic are very interested in homeopathy. And then the other central thing is, as I mentioned before, is education. And it can be just educating people on CAM in general. So sometimes patients will come in and they're on a whole list of supplements, and we'll go through those supplements and try to tease out what is most likely to be beneficial and what might be problematic. And so here's a report of a systematic review done by Ed Mills, who used to be the research director at the Canadian College of Naturopathic Medicine. And it just shows you that there are potential drug-herb interactions that we need to take seriously. So the most common one that you're probably all aware of is St. John's wort for most drugs. And then also we know that garlic could potentially interfere with sequinavir, which is a protease inhibitor. So it's just part of the educational process that we do. So that went pretty quick. Now, are there any specific questions for discussion? Is there anything you want to ask me about?
I have a question.
Sure. Yeah.
Yeah. Let's say if I'm a patient of St. Michael, right?
Yeah.
My doctor though from St. Michael. If I go to your clinic, can I still? Do I have to transfer or? No.
Dude, we're complementary to that. So you still would keep your own physician, and your physicians would handle your medications and your drugs and any diagnostic tests that you need.
But so, I can't go to your clinic and say request for medication.
No, we don't prescribe drugs in Ontario.
Oh. Or with the 412 vitamin?
Yeah.
Let's say if I go to your clinic and see someone, can I get that?
Yes. Yeah.
But as long as I see a physician in your clinic, right?
If you come to our clinic, we'll assess you and do an intake, and then we'll provide you with the Ritava 412. We pretty well give that to everyone. We have some. We have to do a bit of triaging with the medicaments that we have. So the supplements, we can't. We have a very limited budget.
Mm-hmm.
But for the Ritava 412, we pretty well said that anyone that comes in, we'll put them on it as long as we can. So as long as you're a continuous patient at the clinic, and we'll just keep prescribing it as long as.
My doctor is affiliated with St. Michael's also. Dr. Alan Lee, I guess you know him.
I don't know him personally.
He's at Regent Park Community Health Center. Yeah. And I'm seeing another doctor there at St. Michael's, Dr. Ken Balderson.
Yeah.
You know him?
I don't know him personally, but I've heard of him.
You've heard of him, so. Yeah. But I can still come to the clinic there.
Yeah. Most of the physicians are quite cooperative with us, and what we often do is we'll requisition lab work, and they're quite happy to oblige and send it as well, so we know what's going on. There's a few physicians in the clinic that don't, or in Toronto, that don't particularly like what we do, but by far most physicians are cooperative and supportive. So this is I think that the culture of HIV care in Ontario has been more progressive than other types of medicine. So my general sense is that most physicians are fairly supportive of having their patients come to our clinic. I can't speak for everyone because I don't know what they say about her behind my back, but in general, they're quite helpful.
The naturopathic medicine just support the HIV medication or I can quit the HIV medication just using naturopathic medicine?
That's an excellent question. No, I have not seen ever someone be able to avoid taking antiretroviral drugs on natural supplements or natural medicines. There may be some long-term non-progressors who can do that, but I haven't seen anyone. I've seen people try. So not like there will be some clients that'll come into our clinic and they will want to avoid taking drugs, and my concern about that is mainly if someone's exposed to a high viral load for a long period of time, it's going to cause some potentially irreparable damage, and with all the inflammation that's going on. So I recommend that most people start drugs early on, but some clients have refused to take medications, and we don't decline them service or anything like that. But there really isn't, in my mind, an alternative.
A friend of mine, he has HIV. He uses transfer factor, no uses HIV medication. For 5 or 6 years ago, he's doing well.
Yeah.
Do you know transfer factor?
Trophic factors?
Transfer factor.
Tramping.
No.
Yeah, transfer.
Tramping.
Transfer.
Yeah. I'm not. I never seen somebody talking.
Yeah, no, I'm not aware of that. Yeah. And I, maybe there's something. I'm open to the possibility that there is something out there, but I haven't seen anything. So, and I've seen people try. And we've in some cases where someone's decided that they were not going to take medications, we've thrown everything at them, everything we could think of, and we might have slowed down the loss of the CD4 T cells. We might have given them less, maybe their immune system's a better fighting chance on a lower CD4 count, but eventually most patients will take will at some point take their antiretrovirals again.
I have one question.
Sure.
I'm just curious why they keep on changing. Like at the beginning when I got infected, it was 200 at the CD count, and then after that they raised it to 350.
Yeah.
And now they're saying that now it's 500.
Yeah.
I'm very skeptical about that. Like
well,
myself, I'm not on medication. I never took medication in my life. I mean, I've been positive many years.
Yeah. The reason for that, I think, it started with a study called the SMART study, or the SMART trial, and this was a study that remember back in the days when they were doing stretcher treatment interruptions.
Yeah.
So it was a study to look at if you could decrease the adverse effects of the medications by putting someone on medications, getting their CD4 count up to a certain level, taking them off of the medications, let the CD4 count decline to a certain point, and then put them back on the medications again. So they had two groups. They had one group that had the structured treatment interruptions, and they had another group that was just on continuous HAART. And at the end of the study, they found that those who were on the structured treatment interruptions had increased kidney disease, increased liver disease, increased cognitive impairment, increased kidney issues, and so it was the opposite of what they were expecting to find. So while the drugs are toxic and can cause adverse effects, being exposed to the high level of viremia and the inflammation that entails seems to lead to worse outcomes. So so now there's been a revision in waiting. So there's always a balance between the risk of the drugs and the toxicity associated with the drugs and the risk of not treating.
Yeah.
And so they've done a number of analyses where they've looked at large cohorts, and there seems to be some thresholds where it does seem to be best to start treatment, and probably around now 375 or above, maybe 450.
Yeah.
So, and we had to when we were doing the Maintain study, which is the study that I mentioned before about trying to keep people off of medication longer. We actually had to revise the study endpoint of up to 375 because we needed to make sure that we could get people on drugs sooner, whereas before we would have waited probably to 350.
Oh, okay.
Does that?
Yeah.
Yeah. So the problem with the virus is that it does create a pretty nasty state in your body if the viral load is high. Like all viruses.
Yeah,
it creates
just my viral
inflammation.
load has been low for years. Like it's even though I'm not on medication, it's about 10,000, which is the ratio. There's a ratio. They say that.
Yeah. So you may be in a subgroup that does perfectly fine off medication
For now.
Yeah, for now.
Across my fingers.
But you're I would imagine that you're and I can't be certain, but I can hypothesize that you're likely in a greater state of inflammation than you would if your viral load was undetectable.
Yeah.
And whether or not that's clinically important, I don't know. But this is the state. I think this is the type of situation where the micronutrients, such as the Rotava, may have more benefit. So and the beta carotene. I think we've given you beta carotene as well, and some other things. Yeah. So that's the problem with medicine, is that there's a lot of uncertainty, and we don't know. We don't necessarily know how an individual is going to come out at the end. We never know whether or not what our decisions really were good decisions, because you can't have two lives to live. So you make decisions based on the knowledge that you have at the time. So I'm a big proponent of shared informed decision making. So I think that everyone in healthcare needs to have a discussion with their patients about Benefits, risks, and unknowns. And I think ultimately it's up to you to make a decision of what you do. If you're told, if your values are not consistent with going on medications, then that's your choice. That's even in conventional medicine, the guidelines are stating that now. So, and that goes the same with whether or not you want to take statin drugs for lowering your lipids, antihypertensives, whether you want to take Rotava even. I don't think everyone has to take a multivitamin. It's not something that I can say that it's going to have a clinically meaningful benefit in you. But this is just what we offer, and it's up to someone to make that choice. Sorry.
Yeah, I'm still confused about the viral load and the T cell count.
Yeah.
The viral load is how high can you get? Can you go as like 30,000 or unpredictable?
The viral load
yes.
can go up into the millions.
Oh yeah,
So,
and if you're in that state, is it bad or good?
If viral load's high,
Yeah.
Not good.
it's not good. Yeah.
You don't know?
Yeah. So
It's not good, right?
It's not
So
good. Yeah.
unpredictable is always good.
Yes.
I'm talking to him.
Yeah, I know.
So if it's undetectable is ideal.
Okay.
Because if you're on medication, that's the goal. Because if you can keep the viral load undetectable, then it's more likely that the drugs are going to stay effective.
Mm.
So if there's more virus replicating, there's more chance that there may be a virus that emerges, a species that is resistant to the medication that someone's on. So undetectable total viral load suppression, not total, but viral load suppression is the ultimate goal.
Okay.
There's always some virus there,
Mm.
but
It's better than 50. right? It's
It's-
better than 50, right?
You mean less than 40?
Yeah. If your viral load is, sometimes I got 50, sometimes it's like undetectable, right? And in terms of the count, how many count do you have to be a normal? It's like I know my doctor keeps saying 250. If you maintain 250, 200 to 200 is still good.
Yeah, well, the normal absolute CD4 T cell count is up just about 500, like 550 to like I think maybe 1200 or something like that. So it partly depends. So and that's why it's also important to not let the CD4 count get too low, because it's likely that you don't rebuild the CD4's subset as to the same level that you had in the first place. But from the whether or not it's really important to get back into that normal range. I don't know what the absolute benefit is. We know that when viral load's suppressed and the CD4 T cell starts to bounce back up, people do better. And I'm not sure what the cutoff threshold is in terms of those who do ultimately well in the end, compared to those less than that CD4 count.
Because when I was diagnosed, my T cell count is less than 10, and my viral load is 30,000. So
30,000, yeah. Well, that's not too bad.
Is that too bad?
Well,
I thought it was
that's not like 30. If your CD4 count's less than 10, and your viral load's only 30,000, that means you had a fairly good control. As opposed to if your viral load was 100,000 or 200,000 or a million, or so. Relative, and I'm talking relatively. I don't think that's a good state to be in, honestly.
Yeah.
But because there's something called the viral set point, and I'm not sure that haven't seen this talked about much lately, but the better your body was able to bring the virus down to a certain level, the better the prognosis was. So bringing it down to less than 40 is pretty good compared to a much higher number. And that's maybe more relevant back in the early days when the drugs weren't quite as good.
Would you recommend like any certain kind of foods that have, anti-inflammatory properties, or would help as foods that are immune systems that you know of that are not, shown to have any sort of interactions with the HIV medication that we can kind of like be aware of?
Yeah.
And just,
Yeah. The one diet that we know has been fairly good, and don't forget, we're not just specifically dealing with HIV. We're everyone living with HIV is a human too, and they all develop diseases like anyone else does. But the one diet that's been shown to be beneficial is the Mediterranean diet. So we know that it's been shown to reduce clinical outcomes such as cardiovascular disease. And so the basis of the Mediterranean diet are whole grains, lots of fruit and vegetables, legumes, or beans in the diet.
Sorry, can you say it again?
The Mediterranean diet.
Yeah. What's the whole grain again?
So whole grains.
Yeah.
There's a pasta in the Mediterranean diet as well. Nuts and seeds. A lot of olive oil, so you're getting good monounsaturated fatty acids. Potentially a little bit of alcohol, like a little bit of wine in the diet. Very moderate consumption. And chicken, fish, but not a lot of meat. So not a lot of red meat. So some of the studies that have looked at it would say not more than red meat more than once a week. But other Mediterranean diets would guides would say meat maybe once or twice a month. So.
What about those raw fish, like sushi or egg or cheese? Is it like that?
Cheese would be in there, but not. But so if you look at some of the, and we don't know what the actual beneficial aspects of it are. Like we can hypothesize, and we can say it's got lots of antioxidants and it's got lots of vegetables and not too much saturated fat. But saturated fat tends to be one of those things that seems to be lower in balance to omega-3 fatty acids. So
they say the green tea is good for the immune system too. The green tea.
Yeah, green tea contains a number of
apparently it's very good for the
compounds
immune system
that are beneficial. Yeah. Olive oil. A lot of people think of olive oil as just a good quality fat, but it also has some polyphenols that are antioxidants as well.
The first cold press is the most efficient, isn't it? The most with the properties, as far when it comes to olive oil.
Is it? Yeah,
they
I don't
say,
know.
because I have a ritual. I take 1 spoon in the morning of first cold press olive oil.
Do you? Yeah.
Yeah, they say it's supposed to be good. For body functions.
How much do you take? 1 teaspoon?
One soup spoon of a first cold press.
Good, I tried that.
Yeah, that's the most properties. The first cold press.
Yeah, if you look at human evolution, so you take humans back before we had animal husbandry and agriculture. And you're looking sort of at more of a hunting and gathering type society, maybe people living on the coast. The omega-3 fatty acid content of our bodies would be dramatically higher than it is today. So right now we have a lot more omega-6, so nuts and seed oils and that sort of thing. Whereas hunting and gathering societies would have a much higher level of omega-3 fatty acids. So, and that's the diet that we would have evolved to be the most healthy on. So some people would advocate that we really need to get a lot more omega-3s in our diets. The problem is, and you can see on one of the slides I showed, is right up here, you see that everyone's getting fish oil. And I'm not necessarily happy with that, because I think fish oil is important. It's not a cure-all by any means. Like that, the studies have not been, as for mentioned cardiovascular disease, as good as we would have hoped. But the problem is it's not sustainable. So I think we're causing some damage to the oceans and the fish supply by consuming all this fish oil. I would prefer that people get more of their fish from their diet. So even with some concerns about mercury and other problems, I think we need to find a better balance.
How many pills can I take the fish oil?
How many which?
Pill.
How many pills?
One dose, a day.
Well, you could take. Some studies have used up to 10 grams a day of fish oil for pain management. But usually we typically recommend somewhere between 1 and 2,000 a day of the omega-3 fatty acids.
If I take I take the Ratava for 12, and I take 3 fish oil per day, is that too much, or would you say it's too much?
You're taking 3?
3 fish oil per day, plus because there's fish oil also in
No, there's no fish oil in the Ratava.
Oh, okay, yeah. So 3 a day would be okay, I guess. Or?
3 a day would be, yeah. You know, there's not really. I don't see any negative of taking a lot of fish oil, other than the cost and the fact that you have to swallow a lot of pills, and it's not good for the oceans necessarily. But I don't see it as a problem unless you were on like a drug that it was thinning your blood or something like that. Then that would be a problem. But you're not. So.
I heard the benefits of vitamin D.
Yes.
And in your opinion, what's the amount of international units NL can take? Because our goal is to improve our immune system, right?
Yeah.
It could be HIV or any disease. That's our goal.
Yeah.
To keep healthy. But I'd like to know, I'd like to hear from you how much for the international network can take, how many international units of vitamin D?
Well, the Institute of Medicine, which is the group that was commissioned by Health Canada to do a very thorough systematic review of the vitamin D and calcium evidence, they concluded that it was safe to take up to 1,000 or 4,000 a day ongoing. So for ongoing consumption, that 4,000 a day would be safe. Probably it's much higher than that, but they sort of looked at sort of short-term safety data being about 10,000, and then they brought it back down and said, well, if 10,000 is safe, then 4,000 is probably safe ongoing. So it may be that someone doesn't need to take that much, but that's what we consider to be safe. We give 2,000 a day just across the board at Sherbourne, and that's probably beneficial for most people. There are some patients who may require more than that. We don't test everyone, so we don't measure vitamin D in
There's a test we can take for that you were saying.
Yeah, you can measure 25-hydroxyvitamin D. And just recently, the OHIP, the Ontario government, put some restrictions on testing because the cost of testing, because of this vitamin D craze, the cost of testing was just crazy. It was like $20 million a year or something like that had gone down from, or come up from a very small amount. So they put some restrictions on testing. One of them is, the test should be covered, or would be covered, if you have osteoporosis or osteopenia, if you're on a drug that potentially interferes with vitamin D metabolism. So I would say probably you can make a case that anyone on efavirenz could get their vitamin D tested and covered by the government. And people with malabsorption issues could also get tested as well. And now I did some research on, and we're still working on the manuscript for publication, and we looked at vitamin D status in the Canadian HIV Vascular Study. So we looked at 283 patients across Canada, and we measured their baseline vitamin D status, and we wanted to see if there was an association between the vitamin D status and the thickness of their carotid artery. So we were looking for the carotid artery. We use ultrasound to look at the thickness of the lining of the artery, and that gives us an idea of atherosclerosis or cardiovascular disease. And so, but what we found is that in Canada, Canadian people living with HIV or AIDS actually had high vitamin D status, so seemingly higher than the general population. So we were quite surprised by that. We had like the average vitamin D level in our study was about 80 nanomoles per liter, meaning that some people were probably still in the insufficient range, but we were expecting to find a much higher level of vitamin D deficiency, akin to what you see in the general Canadian population. Now, the thing about this study is that it's a very uniform group. So our population is primarily white males, and so and middle-aged males. So these results are probably not generalized to people with darker skin. So many of you have darker skin than me. So which means your vitamin D, you're not as efficient in making vitamin D as someone with light skin. And it wouldn't apply necessarily to women, and it wouldn't apply to the elderly. But what we were very surprised to find a very high vitamin D status in this population. I'm not sure if the problem of vitamin D status in Canadian HIV population is problematic or not, we don't know. I think that probably those of you who are taking favorins should get tested, and you can check, or just take a very high dose level of vitamin D. So the other option is, instead of testing, is to just make sure you're getting vitamin D on a regular basis, particularly if you don't get any sun exposure during the summer. I suspect that there's probably a lot of sun tanning going on in the Canadian HIV Vascular Study.
It is good to take vitamin D all the time.
If you don't get sun exposure in the summer, yes. So certainly between October to the end of April is a good time to take vitamin D. And if you get exposed to the sun in the summer without sunscreen, then you should probably take it year round. Now sunscreen, it's a bit debatable whether or not sunscreen actually blocks the production of vitamin D, but just to be safe, if you're going out, if you're always covered in sunscreen, or if you're always covered, you never go out in the sun, then I think year round is worthwhile. The thing about vitamin D is it's a fairly safe nutrient to take, as far as we know. So taking a little bit of vitamin D throughout the year, I don't think it's harmful. We haven't seen any harm anyways.
What about vitamin C? Vitamin E?
Vitamin E is a different story. So we don't, we used to have vitamin D in Rotava, and I took it out because the vitamin E, anything over 400 IUs a day was associated with an increased risk of cardiovascular disease. So, it's a good word of caution, because nothing is necessarily a freebie. We always have to consider that something that we're taking may eventually turn out to have some negative unintended consequences. So we don't give high levels of vitamin E anymore. It's not something that's used. The more important thing about vitamin E is that it wasn't shown to be beneficial. So we were giving it to all these people for cardiovascular disease prevention, but it didn't turn out in the studies to show any benefit.
What kind of food can we take? What kind of food can we eat in order to get vitamin D?
Vitamin D?
Uh-huh.
It's difficult to get vitamin D from food. Yeah. So salmon would be a fairly good source relative to the sun. So salmon is one food. Milk has a little bit of vitamin D in it, but not much. I think it's 100 to 200 per cup per serving of milk. So it's not nearly enough to get you up to that level. Most like soya milk is fortified with vitamin D2, same with rice milks. And eggs have some vitamin D in it as well. But by far our greatest source, and I think the most natural source to get vitamin E is the sun. Because if you have light skin, you make about 10,000 IUs a day in about less than half an hour. Or so you make 10,000 units in less than half an hour if you're full body exposure. So if you have darker skin, you're going to make less than that. But you can see that you can make a lot of vitamin D very efficiently in the sun compared to having to take it in a diet.
So you can take vitamin D all at the same time with your medication, like your med.
Yes, I'm not aware of any interactions.
So you can take all at once, right?
Yeah. Yeah, one day we might find out that it's better to take them away, but at this point, there's no evidence.
Because I was required to take vitamin D 2,000 a day, and yeah. I'm so worried that I might pass out because I'm taking a 2,000 milligram and I get my pills. I don't want to pass out alone. Yeah. So it's okay to take, right?
Yeah.
Okay.
And you don't have to take another thing. You don't have to take your vitamin D every day.
No.
You could take it 2 or 3 times a week. So if you wanted to take, let's say you intended to take 2,000 a day, you could take 4,000 every 2 days, or 6,000 every 3 days.
It will not be, you don't get high, right?
60, yeah.
I'm not going to get high, right? Okay.
In some studies they give really high doses of vitamin D all.
Yeah, that's what I thought. Yeah.
So they might give 100,000 all at once, and then because in studies compliance is an issue. So instead of giving someone vitamin D every day, they'll give it to them all at once, and then they know for certain that they've actually taken the vitamin. So yeah. So you could take, I think it's what I typically do is I buy you can get very cheap vitamin D from Shoppers Drug Mart. You can get Life Brand. You get these little tiny gel caps, and they're small, and you can just
Yeah, that's what I have, and I got because if I take 3 of those, it become 3,000. So I have to take the 2 bigger pills, and the small one, which is I don't like
the 2 big ones are the medication or the vitamin D.
The vitamin D plus my pills, and
Yeah.
So it's okay to take the 3 small one, right?
Yeah.
Okay.
You can get chewable vitamin D as well.
Okay.
But the thing about vitamin D is we know for certain that that is important for bone health. And reducing fractures and falls. Some of the other benefits are not as fleshed out yet. So we don't know how much of an impact vitamin D deficiency has on cardiovascular disease and immune problems and diabetes and that sort of thing. It's probably related, but who knows? You need to wait for some trial evidence to come out to really establish whether or not there's a causal relationship between vitamin D deficiency and some of these other conditions. Any other questions or comments?
I do have questions. Why? Because my formula from your clinic is with 4 beta carotene a day. Why so important beta carotene for people living with HIV?
Beta carotene was shown by Bill Cameron. He's an infectious disease specialist in Ottawa, and he did a study in patients with AIDS. And what they found is that beta carotene was associated with decreased mortality in those who... They actually stopped the trial early for a number of reasons. One, the product degraded by the end of the study, so they stopped the trial. But he did show, regardless, a mortality benefit. And those with the highest levels of baseline beta carotene also did better. So even though ideally we would like to see the trial come to completion, so we do believe that there is some benefit in beta carotene. We don't know what the exact mechanism is. It may be just as an antioxidant. But so we tend to give beta carotene as well to those who particularly are smokers. So because beta carotene in smokers has been shown to increase the risk of lung cancer. So, but we do use it in some patients, and I would tend to use it more in someone who has a lower CD4 T cell count.
I do have high cholesterol, so I'm on fish oil right now because I'm not taking any cholesterol pills. It reduced my cholesterol level, but not to the standard that my physician was hoping for. So is there any other complementary supplement that can help me to reduce my cholesterol level without taking any cholesterol pills?
That's a good question. There are a number of things that have been shown to reduce cholesterol. So there are a number of herbs that have been used. plant sterols. The problem is that I'm not certain at this point, particularly with some emerging evidence, that the benefit that you get from taking a statin or a conventional drug such as Lipitor or some of the other ones to reduce cholesterol, I'm not convinced that the benefit is all in the reduction of cholesterol. So if the question is, can you give me something that, as an alternative to the statin medication, that will have the same benefit, is I don't know, because we may be able to reduce the cholesterol or increase the good cholesterol, but whether or not that's going to have a clinically important benefit relative to the drug that you can take, I'm not convinced at this point. And this comes from, and this is something I've been thinking about more recently, because there was a study there was a more recent study where they looked at using niacin to increase good cholesterol and decrease triglycerides, and they found that so in this one study everyone was on a statin drug like Lipitor. I forget the name of the actual drug, but and then it might have been Crestor. Was it Crestor?
It's just two Lipitor and Crestors,
yeah. Yeah. So everyone was on the drug, and they added in some patients niacin. So there's a drug called Niaspan, which is like an extended release niacin, so you get less flushing. And the drug, adding the niacin, actually had all the benefits that you would expect. It decreased triglycerides, decreased LDL cholesterol, the bad cholesterol, a little bit, and it increased the HDL, the good cholesterol. But there were no differences in outcomes. So adding the niacin, altering those lipid parameters, had no benefit on clinical outcomes. So it's just a little bit more evidence that we may not understand the relationship between cardiovascular disease and cholesterol. So because we know that the statin drugs work, and they do reduce risk, particularly in people who've already had cardiovascular disease. So it leaves us in a bit of a quandary, because we don't necessarily know that by lowering your cholesterol with natural health products, whether or not we're going to give you the same benefit that you would get from taking the drug. That said, we also don't necessarily know, the statin drugs don't have their best benefit in those who haven't already had cardiovascular disease. So the absolute risk reduction that you get in primary prevention isn't that great. If you've already had a cardiovascular event, it's a different story. So it just goes to show you that there's a lot that we don't know in medicine. I think if I had a cardiovascular event already, I would most likely take a statin drug. If I hadn't, then I would be less clear. And the other thing is, we don't necessarily have everything fleshed out in an HIV population. So we know that being HIV positive is associated with increased risk of cardiovascular disease, but the risk isn't dramatic. So we don't know why that risk is necessarily, and we know there's some other factors that maybe some of the risks that are associated with being HIV positive are not necessarily associated with being with the virus or the treatment. So there's a higher baseline risk. See higher levels of smoking in HIV positive populations as well. So I don't know. Ask me in another month and maybe I'll change my
What do you recommend for psoriasis?
For psoriasis?
Yeah.
Psoriasis, the first thing that we typically do for psoriasis is we do something called an elimination provocation diet. So first we want to see if there's if there are some potential food triggers to the psoriasis. And most people with psoriasis don't have food triggers, but enough do that I think it's a great place to start and to see if there are some issues. So what we do is we get someone to follow a very restricted diet, some basic foods, and then we, for about a 2-3 week period, then we add foods back in systematically to see if there's an activation. So ideally during that elimination period you have an improvement. And then we look to see if there's any foods that might be triggering.
I had psoriasis for around 1 year.
Yeah.
It's still. I have psoriasis for around 1 year.
Yeah.
I still have.
You still have it, yeah.
Is psoriasis contagious? Is it contagious?
Psoriasis, no, definitely not.
What about eczema?
Not contagious.
The coenzyme 10, I'm taking it. I used to have like pain because I'm taking the Crestor now for 5 years.
Yeah.
And I used to have like discomfort, like muscle pain. And I've noticed since I've been taking the coenzyme, it's kind of disappeared.
Yeah, good.
I've been taking it for about 4 months.
Yeah. Yeah, we usually recommend it for those who are on statins to take a CoQ10 supplement.
It seems to help.
Yeah. Yeah. It's been shown to reduce CoQ10 levels.
And what's the benefit of the coenzyme? Actually, it helps for diminishing, I guess, the side effects of the...
Yeah, CoQ10 is involved in the within each cell. There's mitochondria, which are like the power plants of a cell, and the CoQ10 works in the mitochondria. All right. Any more questions? Any comments about your experiences?
Please.
Cam?
You have a problem with ulcer? Ulcer.
Ulcer, yes.
There is some medication, naturopathic medication.
Yeah, there are some treatments that we use for ulcers, mostly herbal medicines. That would be the main thing we do. There's some old formulas that's something called Robert's formula that was put together and used by a lot of physicians back many years ago for ulcers. And interestingly enough, it contains golden seal, which is like an antibiotic. And this was before we knew that ulcers could be caused by H. pylori, which is a bacterial infection.
Oh,
so, yeah, there's a long history of treating ulcers in naturopathic medicine. Yeah. Even before the newer strategy of using the antibiotics.
I always my own is the antidote. My CD4 not up. The higher is 425.
Yeah.
And then now low 200. My own is all antidote at any time. Why?
So it went from 400 to 200.
No, my CD4 is not up.
It's not up. It's not going up.
Not going up.
Yeah, yeah.
Why?
I don't know.
No, I mean is this is for the medicine or my
immune system.
Huh?
Immune system.
No, I want to know is I know it my diagnosis last 3 years ago.
Yeah.
And then is I know it. I take it. The first time I know it. My diagnosis time is my CD4 64. Mm-hmm. My biolo 27,000.
Yeah.
And then is I know it. I take the pill, the HIV medicine.
Yeah.
Next I know it is December, 6 December 2008. And then is January, my CD4 is 72, my biological antibody. And then is I take the pill and is 220 like this. Last year is I get it is the first time my CD4 425.
Yeah.
Yes, is and then my CD4 today.
So it went up and then came back down.
Okay,
Yeah.
to go in down again.
Yeah.
I skating a lot all the time.
Did the percentage change much?
What is that?
The percent? If you look at the absolute CD4 T cell count, the
Yes.
absolute count goes up and down
Up and down,
and
yeah.
But the percent, so you'll see if you're looking at your lab work, you'll see another CD4 and it'll say percent. And that tends to be more consistent. So sometimes the CD4 count may go up like this and down, but if the percent doesn't change much, then it means it's pretty well the same.
Is it not change? The bioload is not the change always.
The bioload's always
Antibody.
undetectable, yeah.
I change a lot of medicine for the HIV medicine.
Yep.
Too many times, my kidney not good. I change again.
Yeah.
I do the treatment against the cancer treatment. I need to change again. I finished my cancer treatment last 5 months ago.
Yeah.
Is my CD4 not up. Always so low. This is I need to take the pill for my CD4 high. Do you know that the CD4 higher for CD4 high medicine? Is that they have?
Is there medicine just to get it higher?
Yes.
We may be able to increase it a little bit, but not dramatically. So, but I'm not sure if the next time you get your blood work, it might be back up again. So it's hard to say. But what we do is I have an assumption that and partly with the micronutrients that we provide, that what we're trying to do is we're trying to optimize the immune function. So we're making sure that at least the immune system has the best chance of success. And so that's why we're giving the baseline nutrients. We're giving the main nutrients that we think are involved in immune function. And from that starting point, then what our assumption is that you'll have a better chance of getting your CD4 counts up. So you never know, and sometimes you will see patients start taking micronutrient formulas and they do better. So their CD4 count may go up. But I'm not sure in your case necessarily what's going on. Who knows? The next time you get it done, it may be higher. So, but if you want, you can come in and we can look at it more closely. I'd be happy to see it.
Like this, my CD4 is
and you're taking your medication on time. And,
oh my God!
Yeah.
Never ever stop. Yeah. It's at the same time, morning 10 o'clock, night 10 o'clock. Is I every day at the same time.
Yeah. Huh. One of the things we're experimenting with now is we have a neem extract. There was a study done in Africa where they showed a very substantial increase in CD4 T cells just on neem, and they used a particular extract that we don't have access to. It was a dramatic increase. So I'm somewhat skeptical of the study results, but we're experimenting a little bit with the neem, and we're trying to evaluate to see whether or not it will increase CD4 T cells. So there are some things that may help a little bit, but you're welcome to come and see us if you'd like. Yeah, I'm there on the Tuesday. There's another naturopathic supervisor on the Wednesday shift. Oh, so before I forget, I brought some brochures in. And if anyone wants to come in, it has the contact information there. And I'll pass it out before we leave. Are there any other questions?
In terms of taking medication, do I have to take my medication on time, or it doesn't matter any time you take, as long as you take every day?
I would suggest you take your medicine at the same time every day. Yeah.
Oh.
I'm not sure about some of the newer long-acting. You mean natural health products or
No,
the drugs?
The drugs, yeah.
Yeah. So some of the newer ones may be more forgiving because they have a long half-life. But I would suggest that you should take it every day at the same time.
The same time?
Yeah. I'm not sure that the pharmacist is the best person to ask in that case.
Okay.
For the supplements, should we take it separately with the drugs, right?
3 o'clock in the morning. Or
What's the timeline? You can,
But anyway, Mr. Wilson.
It really depends on what you're taking. Right? So the micronutrients in Ratava, I don't suspect that they interact much with a number of drugs. But saying that, if you can separate it by a half an hour, I think that would be a good idea. Because we usually, the same as you would, I think about it this way, the same as you would separate things from food.
mm-hmm.
So if your pharmacist tells you to take a medication with food, then you can take your micronutrients with food as well. But you certainly don't want to take certain things with some drugs. So you don't want to take fiber drugs. All right.
Thanks a lot.
If you have any more questions, you know where to find me.
Thank you.
Yeah, you're welcome.
well, thank you very much, Dr. Huff, for